Good morning, ladies and gentlemen. Welcome back to the fourth day of the ninth Jakarta International Chest and Critical Care Internal Medicine GICCIM 2021 live webinar. My name is Julian Huningkor, and I will be your host for today's event. Today we will be having 3 lecture sessions, and we are sure that today's session will enrich our knowledge and understanding even more. Before getting into the sessions, we would like to remind you that the first is all the participants of GICCIM 2021 are expected to attend the webinar attentively. Certificate will only be given to the participant who attend at least 70% of the whole webinar. Second, the participant may use the Q&A feature in the Zoom if they have any question for the speaker. You can ask the question in the middle of the lecture without waiting for the speaker to done speaking. And every week on Sunday after e-poster sessions, there will be a door prize for the attentive participant. For the first 2 weeks, the prizes will be Bluetooth speakers, smart watches, and Bluetooth earphones. And there will be also added a bicycle as the grand prize on the final week. So, ladies and gentlemen, we are now entering the 10th session of GICCIM 2021, in which we will discuss about the updates on community-acquired pneumonia. Speaker in the sessions will be Dr. Heni Retnowulan, spesialis penyakit dalam konsultan pulmonologi, and Professor Lorraine B. Ware, MD. And the discussion will be moderated by Dr. Emi Hermianti, spesialis penyakit dalam konsultan pulmonologi, konsultan intensive care. Dr. Emi is a teaching staff at Pulmonology Division, Department of Internal Medicine, and the Faculty of Medicine Universitas Padjadjaran, Hasan Sadikin Hospital, Bandung. Without further ado, Dr. Emi, the floor is yours.
Okay. Thank you. Thank you very much to the committee. Good morning,
Ini udah mulai
Dr.
share screen ya berarti?
Professor Lauren.
Udah ya?
Welcome from
Ini belum dong?
USA.
Hah? Ini belum? Oh ini belum? Terus gimana
Now,
caranya?
okay. Speaker,
Ya.
you will present Dr. Henny. Would you like to present your presentation? Your time is 20 minutes. Okay, time is yours.
Okay, thank you. Good morning, everyone. Assalamualaikum warahmatullahi wabarakatuh. In this morning, I would like to present my material with the title Updates on Community-Acquired Pneumonia Management from Outpatient to Intensive Care. And this morning, I have 6 topics: the risk factors, impact, causative pathogen, diagnosis of CAP, and the fifth topic is antibiotic stewardship, and the last one is multidimensional effect of the macrolide. The first topic is the risk factor of CAP. It is categorized into 3 subtopics: sociodemographic and lifestyle factors, and secondly, comorbidity or clinical condition, and the last one is therapeutic risk factors. The first one, for sociodemographic and lifestyle factors, in this slide shows many variables and represent in the relative risk value. It is based on the systematic review result, and all of these values statistically significant. There are per year increase of age, and then smoking status at X and current smoker, and then the degree of active smoking, more severe active smoking tends to higher health of CAP. And then I'm underweight and alcohol intake more than 80 grams a day, and contact with pets. Secondly, the comorbidity or clinical condition as risk factor of CAP. Uh, as the shape, all of these variables represent on the relative risk value based on the systematic review, and all of these values statistically significant. They are hospital admission in the last 5 years, nasogastric tube, history of CAP, and history of frequency of CAP. More frequency of history CAP tends to higher risk of CAP. And then diabetes, heart failure, heart valve disease, chronic bronchitis, non-active pulmonary TB, epilepsy, cancer, HIV, asthma, dental dysesthesia, dental prosthesis, history of CAP in the childhood period, orodental or periodontal disease, visit to dentist in the last month. And the last one, therapeutic risk factor. As the same, reveal or represent in the relative risk value, and all of these variables statistically significant. The drugs are amiodarone, diuretic, acetylcysteine, xanthin, oral corticosteroid, inhaled corticosteroid, inhaled beta-agonist, inhaled anticholinergic, oxygen therapy, and inhaler with or without spacer. And the second topic is the impact of CAP and quality of life. This slide shows the quality of life is measured by using the short form statistics. This questionnaire has 8 dimensions: physical functioning, role physical, bodily pain, general health, vitality, social functioning, role emotional, and the last is mental health. Whereas here, the dotted line represent the population without the disease, the population without the pneumonia. Whereas the dashed line here represent the population with the disease or suspected pneumonia. This graph shows the dashed line here have a lower score compared to the dotted line. Means the population with the disease with the suspected pneumonia have lower score of the short form 36 compared to the population without the disease for all dimensions. At the home visit, 1, 6, and 12 months. Means CAP impact to the quality of life until 1 year later after discharge from the hospital. Again here, the quality of life is measured by European Quality of Life for Dimension Questionnaire and Visual Analysis Scale. This questionnaire has 5 dimensions: mobility, self-care, usual activity, pain or discomfort, and the last one is anxiety or depression. The dotted line here represent the population without the disease, And the dashed line here represent the population with disease or suspected pneumonia. For all, the dashed line shows higher proportion reporting the problem compared to the dotted line. Means the population with disease has a lower quality of life compared to the population without the disease. At the home visit, 1, 6, and 12 months. Means the quality of life is impacted by CAP until 1 year after the patient discharged from the hospital. And the last one here, the quality of life is measured by using QALY, quality of life adjusted year. all the quality of life score times to 1 year time period. The maximal score is 1. There are two populations here: suspected pneumonia case population and population without the disease is measured 1 year post-discharge. For all cases, there is a mean difference between population with disease and non-disease, 0.13 of 1 total point score. For survivor only, there is a mean difference 0.1 of 1 total point score. Means population with the disease has lower Kali score than population without the disease. The third topic is causative pathogens. As we know, the causative pathogen of CAP consists of bacterial, viruses, fungal, and mycobacterial. The most common causes of CAP is Streptococcus pneumonia, and after that, Haemophilus influenza, gram-negative bacilli, Staphylococcus aureus, Moraxera cataralis, virus, and co-infection between bacteria and virus. But in the last 6 decades, from 1940 to 2020, there is a trend decreasing Streptococcus pneumonia and Haemophilus influenza incidence as the etiology of CAP. This phenomenon related to widespread coverage of pneumococcal vaccination and herd immunity related to vaccine, and the big one is impacted by COVID-19 pandemic. Diagnosis of CAP mainly based on the imaging. The most common method for diagnosis CAP is just X-ray, but the other ones we can use by using chest CT and ultrasound. For gram stain and culture of lower respiratory tract secretion, blood culture and pneumococcal urinary antigen are not routinely applied just for severe cases. Legionella urinary antigen is applied when the patient live in the outbreak area or who did a traveling. Testing for influenza is applied for patients who live in the area with high activity transmission of influenza. And serum procalcitonin is not routinely done. If we found the result more than 0.5, the patient tends to have a bacterial infection, whereas lower than 0.1, the patient tends to have a viral infection. But antibiotic has to be started regardless the procalcitonin level. This slide shows a patient setting. Patient setting is used for determining where the patient has to be placed, where the patient to be cared by using PSI, Pneumonia Severity Index, and CURB65. If we found less than 70 point of PSI or 0 to 1 CURB65, it is classified to outpatient. When we found 71 to 130 point score of PSI or 2 point score CURB65, it is classified into outpatient or brief inpatient. More than 130 of PSI or more than 3 point score of CURB65, the patient has to be hospitalized, but if the patient need mechanical ventilator or vasopressor, the patient has to be placed in an ICU. The fourth topic is antibiotic stewardship. This is the summaries of the stewardship. CAP patient is diagnosed by using imaging based on the PSR or CURP65. It is classified into outpatient and inpatient. For outpatient, we have to look first, is there any comorbidity or not? For inpatient, based on the minor and major criteria, classified into severe and non-severe, and after that, we have to look, is there any risk factor for MRSA or Pseudomonas? Based on the history or evidence of patient MRSA or Pseudomonas isolation, all the patient receive parenteral antibiotic in the last 90 days when he was hospitalized. For outpatient without the comorbidity, the chosen antibiotic is amoxicillin 1 gram 3 times daily, doxycycline 100 milligrams 2 times daily, and macrolide, which is consists of azithromycin, clarithromycin extended release. For outpatient with the comorbidity, the chosen antibiotic consists of combination therapy and monotherapy. For combination therapy consists of amoxicillin clavulanate or cephalosporin combined to macrolide, whereas for monotherapy, we can use respiratory fluoroquinolone, levofloxacin, moxifloxacin, and gemifloxacin. For inpatient, when classified into non-severe cases, the chosen antibiotic consists of combination and monotherapy. Combination consists of beta-lactam combined to macrolide. Beta-lactam we can use ambisulbactam, cefotaxime, ceftriaxone, and ceftaroline. For inpatient with a severe disease without the risk factor of MRSA or Pseudomonas, the chosen antibiotic combination between beta-lactam and macrolide or combination between beta-lactam and respiratory fluoroquinolone. Whereas for the patient with severe case and the risk factor of MRSA or Pseudomonas, the chosen antibiotic for MRSA are vancomycin or linezolid. For Pseudomonas, we can use piperacillin tazobactam, cefepime, ceftazidime, aztreonam, meropenem, and imipenem. That is the summary of steward antibiotic. CAP patient, based on the imaging and PSI and CURP65, is going to define into outpatient or inpatient. For a patient, we have to look first, is there any comorbidity or not? And based on the major and minor criteria, inpatient is classified into non and severe cases. And after that, we have to see, is there any risk factor for MRSA or Pseudomonas? This slide shows recently approved antibiotic for lower respiratory tract infection. This antibiotic cover for gram-positive and gram-negative. For gram-positive, there are ceftaroline, tedizolid. Tedizolid is a new generation of linezolid and telavancin. For gram-negative, there are ceftazidime avibactam, aztreonam avibactam, meropenem vaporbactam. For both coverage, gram-positive and negative, there are tetracycline, plazomicin, venlafaxine, delafloxacin, eravacycline. Uh, this is a different method. It is inhaled antibiotic. From this method, we it has some benefit. Firstly, the antibiotic achieve directly to the site of infection, and secondly, the antibiotic achieve the local high dose without systemic accumulation, and the flora of the gut is less changed. This method better when performed by using tracheal instillation. There are four regimen: tobramycin, amikacin, aztreonam, and levofloxacin. And the last topic of my material is multidimensional effect of macrolides. Uh, Macrolides effect has three effects on CAP. Firstly, modulation of immune cell function. Secondly, modulation of epithelial and endothelial cell function. And the last one has effect of antimicrobial function. For immune cell function, macrolide effect on neutrophil, T cell, B cell, monocyte, and dendritic cell. And also, secondly, macrolide effect on airway epithelial cell, vascular endothelial cell, and the last one as antibacterial agent, mainly for Streptococcus pneumonia, MRSA, and Pseudomonas aeruginosa. The first mechanism on the immune cell function, most of these cells produce many cytokines, and the last result, the last effect, decrease of recruitment, migration, and elastase, and improve the apherocytosis process, and decrease proliferation and chemotaxis of this cell, and increase of apoptosis. For RV epithelial cell, produce cytokines, and then the final effect is decrease mucus secretion and improve the ciliary function and induce of decreasing recruitment of the neutrophil. In the vascular endothelial cell, macrolide suppress the VCAM1 production, and the effect is suppress the angiogenesis process. As the antibacterial, macrolide suppress the pneumolysine product of Streptococcus pneumoniae and decreasing the coagulase and motility from MRSA and Pseudomonas aeruginosa. This is the summaries of effect of macrolide. Firstly, in the immune cell, and then in the RV epithelial cell, vascular endothelial cell, and as antibacterial agent. I think it's all. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Stop.
Thank you, Dr. Henny, for your precise time for presentation. I would like to read your CV. Educational background is from Gajah Mada, or for the graduate from the sekolah kedokteran, and then the master program, and then the internal medicine, and also the consultant for pulmonary. Okay, the latest position is staff of pulmonology in internal medicine and many of association. Thank you very much for Dr. Henny. Okay, the next presentation is come from Professor Lauren. Professor Lauren has many uh, education and skill in many fields for internal medicine, professor in internal medicine, and also from pathology, anatomy, immunology, and also from pulmonary and critical medicine. Okay, your time is 20 minutes, professor. Time is yours.
Good morning, Selamat Pagi. I want to thank you for inviting me to this conference. I wish that I could be there in person. Hang on. Having a little trouble. There we go. These are my conflicts of interest, and I want to thank Dr. Semler for providing some of the slides for this talk. So what I'm going to be talking about today is fluids and vasopressors in sepsis and ARDS. I'm going to start with talking about what the goal is with fluids and vasopressors, and then switch to how we achieve that goal and talk about choice of fluid and vasopressors, dose of fluid and vasopressors, and then end very briefly by talking about de-escalation of fluid therapy. So what is the goal with fluids and vasopressors in sepsis and ARDS? Well, the goal here is to optimize left ventricular filling, to optimize cardiac output, so that we can maximize tissue perfusion. Because we know in patients with septic shock, they often have tissue hypoxia due to hypoperfusion, and this leads to organ dysfunction. We'd like to reverse that with fluids and vasopressors and reverse shock and reverse hyperlactatemia. But this has to be a balance because we need to do this without overdoing it and without overfilling the left ventricle, leading to elevated left ventricular end diastolic pressure, which could lead to pulmonary edema and could impair cardiac function. We don't want to overdo it and cause tissue edema because that can impair organ function. And we'd like to minimize unwanted side effects, for example, side effects of vasopressors such as tachyarrhythmias. Finding this balance is really challenging. And sometimes it feels like we're trying to do it with a blindfold on because it's very hard to optimize fluid and vasopressors in an individual patient, as you will see. So if this is the goal, how do we achieve it? Well, I'd like to start by talking about choice of fluid and vasopressors. There are a lot of choices for IV fluid. If we think about IV fluid and go down this pathway, we could give a colloid. We could pick a human colloid, which would be albumin, or a synthetic colloid, of which there are many. Or we could pick a crystalloid. And if we pick a crystalloid, we again have a choice. We could pick an unbalanced crystalloid, such as normal saline, or a more balanced crystalloid, such as lactated ringers or plasmolite. So how do we navigate this choice? Well, if we think about what we're trying to do when we resuscitate a patient with sepsis, we're trying to increase the plasma volume, to increase left ventricular filling. So we want to give something that's going to stay in the plasma. If we give a colloid that has macromolecules in it that will stay in the circulation, then theoretically, that will stay in the plasma better than a crystalloid that's going to distribute between the plasma and the interstitial space. So what about colloids in sepsis? What's the data? Well, let's talk first about albumin. Human albumin is synthesized by the liver, and in normal humans, it provides 70% of plasma oncotic pressure and can have some other beneficial effects, such as binding nitric oxide and delivering it, preventing lipid peroxidation, and regulating inflammation. And we can give it as fluid replacement, 4 to 5% albumin, or we can give it to really support colloidal pressure with 20 to 25% albumin. So what's the data? Well, this is the SAFE trial, which was published in 2004. It was done in about 7,000 ICU patients comparing 4% albumin versus saline for fluid resuscitation. You can see that the patients who received albumin in this study, on average, got a little bit less fluid each day. So they required a little bit less fluid. But if we come down here and look at mortality, there really was no benefit for albumin versus saline in this large study of 7,000 patients. Maybe a hint towards some benefit in patients with sepsis, but not significant. This was followed by the ALBIO study, which studied 1,818 septic ICU patients, giving them 20% albumin versus crystalloid and targeting a serum albumin of 3 grams per deciliter with the albumin supplementation. You can see that they achieved a higher albumin in the albumin group, and that the net fluid balance was a little bit lower when the patients who got albumin. So they required less fluid overall and also had less vasopressor requirement. However, the mortality was exactly the same between the two groups. So there was no benefit. There was a trend towards a benefit in a post hoc analysis of patients with septic shock, but this was post hoc and not seen in the overhaul trial. So what can we summarize about albumin versus crystalloids? Well, overall, we're not really seeing a benefit for mortality in patients with sepsis. We get a small benefit in terms of volume, maybe a little benefit in terms of hemodynamics, nothing really for outcomes, and they're very expensive. Albumin costs 100 times more than crystalloid. Shouldn't be used in traumatic brain injury, and perhaps we need more data in patients with septic shock, but not much good data at this point to suggest that we should use albumin routinely to resuscitate patients with sepsis. So what about semi-synthetic colloids? Well, there's a lot of them. Gelatins, dextrans, and hydroxyethyl starches are the most common ones that are commercially available. The ones that have been studied the most in sepsis is the hydroxyethyl starches. These are synthesized from a corn-derived polymer, amylopectin, and there's a variety of different preparations. And I'm just going to walk you through a few trials of these synthetic starches, which, like albumin, provide a colloid that should stay in the vasculature theoretically. So this was the VICEP trial published in 2008, 537 ICU patients with sepsis, randomized to 10% pentastarch versus lactated ringers. The patients who got the pentastarch had less volume resuscitation required, a ratio of about 1 liter to 1.3 liters, and had some improvement in hemodynamics, but there was a lot more kidney injury in the pentastarch group, and the mortality was substantially higher, which you can see here in this survival curve, which is much lower in the pentastarch group. So adverse effects of randomization to the pentastarch arm. Similarly, in this trial of hydroxyethyl starch versus Ringer's acetate in 800 sepsis patients, there was no benefit, no difference in hemodynamics, more kidney injury in the hydroxyethyl starch group, and higher mortality, lower survival in the hydroxyethyl starch group. And one more trial, the CHEST trial, 7,000 ICU patients, hydroxyethyl starch versus saline, a little bit lower fluid in the starch group, no differences in hemodynamics. The mortality, not a lot different in this study, but look at the serum creatinine. The red line here is the hydroxyethyl starch, much higher. So again, a signal for acute kidney injury. So to summarize these studies of semi-synthetic colloids in sepsis, there is a very concerning signal for acute kidney injury with these hydroxyethyl starches. The risk of kidney injury and bleeding may be setting and patient dependent, but the overall signal is a signal of harm. And there's no trial right now that shows a benefit in primary outcomes. So overall, there's really no evidence to support using semi-synthetic colloids, and in fact, they should be avoided. So that leaves us with crystalloids as our primary mode of resuscitation in patients with sepsis. But again, here we have choices. We can choose saline, normal saline, and the composition is shown here, just sodium and chloride, or we could choose a balanced solution such as lactated ringers or plasmolite, with the big difference here being less chloride, with the anions being organic anions such as lactate in lactated ringers or acetate in plasmolite. So what difference does it make? Does it really matter which one we use? Well, there has been a theoretical concern for a long time that this high chloride could cause problems. So we all know if we give a patient a lot of sodium chloride, they will get a hyperchloremic metabolic acidosis. But what we have not known until recently is whether that actually is harmful to patients. So I just want to walk you through the SMART trial, which was published in 2018. This was a very large trial. It was single center, but enrolled over 15,000 patients at Vanderbilt in 5 different ICUs. This was a pragmatic trial where each ICU was randomized by month to in alternating months to use balanced crystalloid or saline as the primary mode of resuscitation and maintenance fluid, and then every month it switched. The trial was done over about 1.5 years, and almost 16,000 patients were included in the primary analysis. So what happened? When patients received saline as their fluid, their chloride went up, and this was not as much of a problem in the balanced group. Similarly, when patients received saline, their serum bicarbonate went down. This did not happen to the same extent in the balanced resuscitation group. So we see difference in serum electrolytes. What about adverse effects? The primary outcome in this study was major adverse kidney events, or MAKE-30, which is a composite of persistent renal dysfunction at day 30, need for new renal replacement therapy over the first 30 days, or death. And you can see that that outcome occurred more often in the patient group who received saline compared to the group who received balanced crystalloids. So more death, more renal replacement therapy, and more persistent kidney injury. This was particularly prominent in patients with sepsis, as opposed to patients without sepsis. So also this effect seen in the SMART trial, this is the subgroup with sepsis, was consistent with other smaller trials that studied patients with sepsis that had a similar effects, although with the small sample sizes, not significant. So for sepsis patients, when you're thinking about crystalloid, a balanced crystalloid such as lactated ringers causes less acidosis, less vasopressors, I didn't have time to show you that data, less dialysis, and less death. There are 2 other large similar trials that are ongoing now. I believe the BASICS trials has finished enrollment, so hopefully we will see results soon. But what I would recommend at the moment for choice of IV fluid in sepsis resuscitation is balanced crystalloids as the first-line therapy. Lactated ringers or plasmolite, we don't know if one is better than the other. Albumin is second line, it's expensive, it may improve outcomes in some subset of patients, but we don't have great data to guide us. I use saline very rarely, and I would never use starch. Moving on, what about a vasopressor? If we need a vasopressor to resuscitate a patient with sepsis, this is an area where we have a lot less data. We have a little bit of data. I would say the preponderance of data would suggest we use norepinephrine as our first-line pressor. Why? Well, it clearly has less adverse effects such as tachyarrhythmias, mesenteric ischemia, skin necrosis compared to dopamine, phenylephrine, or epinephrine. And there is some data to suggest it may improve mortality compared to dopamine. So this is a meta-analysis here comparing norepinephrine to dopamine. These are clinical trials that compared these 2 and looked at mortality. I want you to notice 2 things here. First, the total number of patients isn't very big. So these were all very small studies. And the second thing is that in this meta-analysis for mortality, the relative risk was favored norepinephrine versus dopamine. Now, when we get to adding a second pressor, if fluid and norepinephrine are not resolving septic shock, I think we have even less data to drive our choices at this point in time. My second pressor of choice would be a low fixed dose of vasopressin, and you also need to consider if there's a cardiogenic component to the shock, perhaps adding an inotrope. So that's all I'm going to say about choice of vasopressor. Moving on, so we've talked about which fluid we should use, which vasopressor that we should use, but how much? So I want to shift gears to talking about the dose of fluid and vasopressors. And I'm really going to focus here on the early phase of sepsis, where we're talking about rescuing a patient in shock, trying to restore tissue and organ perfusion, and optimizing cardiac function. I'll touch very briefly at the end on de-escalation of fluid therapy in ARDS. So what are we trying to achieve when a patient with septic shock in that early rescue phase? Well, we're trying to restore tissue perfusion. We know that patients with shock have reduced tissue perfusion that leads to decreased oxygen delivery, that leads to cellular derangements that lead to organ dysfunction. In shock, we have a low blood pressure, and our blood pressure is driven by our cardiac output, heart rate times stroke volume, times our systemic vascular resistance. In patients with sepsis, typically, the stroke volume is reduced and the SVR is low. And what we're trying to do in that rescue phase is restore the stroke volume. So in this Starling curve here, we have a low left ventricular end diastolic pressure. We're trying to resuscitate with fluid, walk the patient up this line here, increase the stroke volume. With vasopressors, we're trying to reverse the vasodilatation and increase the SVR. So how do we walk a patient up this curve? Typically, we give a rapid fluid bolus of at least 500 cc's over less than 15 minutes. Once we've done that rapid fluid bolus, then how do we optimize the total amount of fluid we're going to give a patient to try and optimize that stroke volume, optimize cardiac performance without over-distending the left ventricle and increasing left ventricular end diastolic pressure? Well, this is where it becomes really challenging and where I think we often have the blindfold on. Despite the fact that we have a lot of ways at the bedside to try and determine if a patient is adequately volume resuscitated, none of them really work very well, and none of them give us the rapid answers that we're looking for. For many years, we relied on static measurement invasively of central venous pressure and pulmonary artery occlusion pressure, but these have really been supplanted recently by measures that are dynamic. So what happens when we give an increase in central volume by raising the legs passively? Or if we give a fluid bolus, what happens to pulse pressure variation? What happens to stroke volume variation? What actually happens to cardiac output? Can we dynamically measure if a patient is fluid responsive? These methods have become very commonly talked about as ways to assess whether a patient will respond to more fluid with an increase in stroke volume. But what I want to say is a word of caution here. So our goal is to find out whether we're on this part of the curve, where giving more fluid will increase left ventricular end diastolic pressure and increase stroke volume. Or are we on this part of the curve where giving more fluid is not going to accomplish anything other than to raise LV-EDP and increase our risk of developing pulmonary edema? The problem with fluid responsiveness measures, these dynamic measures, there's several issues. One is that they typically require invasive monitoring, which may not always be available. A second issue is that if we define, if we define fluid responsiveness as an increase in stroke volume greater than 10 to 15% after administration of 500 cc fluid bolus, then 50% of you who are watching this talk are fluid responsive right now. So what does that mean? I'm not sure. Most patients who come in the ICU are fluid responsive at admission. By 48 hours, less than 5% are fluid responsive. But the biggest caveat here that I want to emphasize to you is that although we have a lot of nifty ways to measure fluid responsiveness now, we don't actually have any data to suggest that using fluid responsive dynamic measures to determine whether to give patients fluid actually improves clinical outcomes. The data we have suggests it doesn't. So in this meta-analysis here of 4 randomized trials of measuring fluid responsiveness effects on cardiac output, there was no mortality benefit. Now, granted, this is a small number of patients, 180 or so in each group, but we don't have any data right now to suggest that these methods actually improve outcomes. So we need more studies. So you're probably thinking, well, okay, if you don't want me to do fluid responsiveness, how much fluid should I give? And I'd say we really don't know the answer at this point. And some of the things we think we know turn out to be wrong. This trial was recently published in JAMA. This was a trial done in Zambia of an early resuscitation protocol for early sepsis that emphasized early resuscitation with fluid, monitoring of jugular venous pressure, and transfusion if needed for a hematocrit hemoglobin less than 7. The patients in the early resuscitation group got more fluid. They were probably better resuscitated than the usual care group. But look at this as a survival curve. They actually had a much higher mortality. So even the things we think we know aren't always right. In this practice setting in Zambia, an early goal-directed resuscitation protocol in sepsis had worse clinical outcomes. So where does that leave us? How much fluid should we give our patients? I think it's very hard to determine, but I think that this is a good place to start. The Surviving Sepsis Campaign recommends 30 cc's per kilo bolus for patients in shock or with elevated lactate, and then add a vasopressor. We need more data, obviously. There's compelling reasons to think we should use a lot of fluid. There's also compelling reasons to think we should limit fluid. Giving fluid augments preload, decreases vasopressor use, and increases microcirculatory flow. But limiting fluid and using vasopressors early could reduce positive fluid balance, could reverse vasodilation in sepsis, and could prevent worsening of pathologic edema, which is a big problem, especially in the lung, where we develop acute respiratory distress syndrome. We don't have great data to answer this question right now, but there are trials ongoing. The CLOVERS trial is a pedal network trial in the US that's going to is testing fluid restrictive sepsis resuscitation, where fluid is limited and vasopressors are started early and fluid is given as a rescue, versus a fluid liberal protocol where patients get a lot of fluid up front, and if they're still hypotensive, then they move to vasopressors. This trial is going to enroll 2,300 patients. It was doing great until April 1st, 2020, and we all know what happened in April of 2020, but this trial is starting to enroll again, and hopefully we'll get some answers. So I'm almost out of time. I just want to talk really briefly about de-escalation of therapy. Once the patient is out of shock, what should we do? Well, if we think about a patient with ARDS here on the right side of this graph, we know that this alveolar capillary barrier is leaky. And so if we have a leaky barrier and we have elevated pressure in the pulmonary microvasculature, that's going to be a driving force for edema formation. The fluid and catheter treatment trial, which was published almost 15 years ago now, tested a conservative fluid strategy in patients with ARDS, where fluid intake was limited, patients were actively diuresed, and they achieved almost a net even fluid balance over 7 days, versus a liberal fluid strategy, which is really what we tend to do when we're not paying attention, and what happened in 2 other ARDS clinical trials when fluid was not the subject of the trial. Patients gained about 1 liter a day. So in that trial, you may be familiar, the conservative fluid arm, patients got off the ventilator, they were more likely to be breathing without assistance over time in that conservative fluid restricted arm. So once patients are out of shock, particularly patients with ARDS, we don't need to give them any more fluid. In fact, we need to get fluid off and try and dry them out, get back off all the fluid we gave them when we were resuscitating them. I'm just going to finish by showing you these data from a study we did in our own ICU, looking at several hundred patients with ARDS who were phenotyped for ARDS by myself and another physician for a research study. We went back and looked whether the clinicians recognized ARDS. If they did, that's the orange bar. If they did not, that's the blue bar. And then we looked at fluid balance. If clinicians recognized that the patient had ARDS, they tried to dry them out and gave them diuretics. That was less likely if they did not recognize ARDS. Same thing for cumulative fluid balance, lower when the clinicians recognized ARDS than when they did not. So this is my plug for making the diagnosis of ARDS so that you can manage the fluid appropriately in the de-escalation phase. So just to summarize, the goal of fluid and vasopressor therapy in sepsis and ARDS is prevention and reversal of tissue hypoxia. Crystalloid therapy is first line, balanced crystalloid is preferred. Start with a rapid fluid bolus, add a vasopressor if needed. Norepinephrine is first line. Optimizing fluid therapy, very challenging. We need more data. And finally, in ARDS, restrict fluid once the patients are out of shock. So thank you, Terima kasih, and I'd be happy to take any questions. There might be a question in the chat, but it's not in English, so I can't answer it.
Izin dok, suaranya belum masuk, mungkin masih di mute dok, maaf. Dr. Emi. I'm sorry, Dr. Hemi, and all the presenters. Maybe Dr. Hemi have some kind of trouble in the technical. Maybe I will read some of the question from the participant. Maybe I will ask the question while Dr. Emi finish the troubleshooting she has. Maybe I will ask for Prof. Lorraine. Are you still with us, Prof. Lorraine? Do you hear my voice?
Yes. I can. Yes.
I will ask the question for maybe for moderator. For Prof. Lorraine, there are two questions. The first question is, how do we make clinical approach for fluid resuscitation in patient with sepsis with comorbidities with cardiac failure? What is the best fluid management for such patients? And the second question, if HES is our only option for fluid management, how should we manage the patient with sepsis? Needed fluid therapy. As we learned in your presentation that HES fluid therapy will induce risk of acute kidney injury.
The second question.
You want me to repeat the second question?
I think I understood it. If HES is the only therapy available, what should we do?
Oh,
Was that
it's
the
the only
question?
therapy. Yes. Right. That's right. Is that the only option?
It's hard for me to imagine that you would have HES and not a crystalloid. So I don't really know how to answer that other than I think the preponderance of data would suggest that has a lot of adverse effects. And I think the issue is that although it's a colloid and we think that it would stay in the circulation, probably what's happening is that it's penetrating the kidney and then it's causing an osmotic swelling in the kidney that's harmful to the kidney.
Yes, thank you, Professor Lorraine. Maybe in some of the peripheral hospital, maybe if there's some kind of problem, in peripheral hospital they only have HES in their hospital. And maybe for the first question, maybe I should repeat the question. In the first question for Professor Lorraine, how do we make clinical approach for fluid resuscitation in patient with sepsis with comorbidities of cardiac failure? What is the best fluid management for such patients?
I think that's a really good question, and there's a lot of complexity to that question because you could have diastolic heart failure, systolic heart failure. In that situation, I think it's really important to be trying to monitor your filling pressures, perhaps using bedside echo, perhaps invasively. And you may need to use a combination of vasopressors and inotropes to try and minimize fluid to avoid developing pulmonary edema. But I don't think that there's one answer that's going to fit every patient. That's going to require some personalized attention at the bedside.
Thank you, Professor Lorraine. And maybe we ask Dr. Amy again. Dr. Amy, can you? Okay, I'm sorry. Maybe there's a technical issue. I will continue to read the question for the for all the present. For the next question, for Dr. Henny. Dr. Henny, can you hear me?
Yes.
Yes. This question from Dr. Igusti Agu Ayuputu Sri Dharmayani. The question for Dr. Henny is regarding the multidimensional effects of macrolide. How much dose and how long duration of therapy for having the effect? Does this effect is same for all drug in macrolide class? Thank you, Dr. Henny.
Thank you. For the macrolide, should be continue until the patient achieve a stability parameter and for no less than 5 days. The clinical parameter can be used by using improving heart rate, respiratory rate, blood pressure, oxygen saturation, and temperature. Ability for eating and normal mentation. there is no disorientation here. And then for the dose, for azithromycin, we can use 5 milligram daily. For clarithromycin, 500 milligrams 2 times daily. For clarithromycin extended release, 1 grams daily. Yeah.
Any? Maybe we continue to our next question from Pangeran Putra Nurizal. For initial use of vasopressor, how much dose of epinephrine should we use? Also, is it recommended to use more than one vasopressor if the shock still unresolved? And what kind of vasopressor we should combine with norepinephrine? I think the question is for Professor Lorraine because it is asked about vasopressor. Thank you.
Yeah, so I would recommend for first line vasopressor, at least in our practice, in our ICU, we use norepinephrine as our first line pressor. When we start, at low dose, 5 mics per kilo per minute. When we get above about 30, then we'll add a second pressor. Our pressor of choice for a second pressor is vasopressin, so different mechanism of action. But we use a low dose of vasopressin, 0.04, and we do not titrate it up because at higher doses, you can start to have real problems with digital ischemia. You can have complications such as blindness develop from ischemia. So we stick with a low non-titrated dose of vasopressin. If the patient is still in shock, you believe they're adequately resuscitated, now on 2 vasopressors, I think, depending on the clinical situation, determine whether you need an inotrope, if there's any cardiac dysfunction, or if you want to add a third vasopressor. I don't think there's any good data to guide choice of a third vasopressor. We sometimes use epinephrine, occasionally use Ang2, although only in very selected patients, and I can't honestly say I've ever seen a patient have a great response to it, although I know some patients do. I just haven't found it to be particularly effective in that setting of refractory shock.
Thank you, Prof. Lorraine. I think there's another question. This question comes from Dr. Gurmeet Singh. For Professor Lorraine. Prof, what is the maximum diuretic dose or maximum negative fluid per day for ARDS patients from day?
Yeah, that's a good question. I think it's important when we talk about the FACT trial to actually go back and read it and see what they did. They evaluated every patient every 4 hours in terms of, were they in shock? If they weren't in shock, what was their CVP or wedge pressure? And if it was above the threshold in the conservative arm, they got diuretics. So the patients got diuretics every 4 hours if they were still had a CVP above 4 or a wedge pressure. I can't remember. I think it was above 8. They got diuretics every 4 hours. So there was no maximum dose in that trial. They could get 40 milligrams of Lasix every 4 hours if needed. Even with all that diuresis, they really only achieved, if you remember that graph I showed, they achieved even fluid balance. So patients in the ICU get so much fluid in their medications, in their nutrition, that it's very hard to actually achieve a negative fluid balance. So one more point, what I usually try and do, since we don't often have a CVP or a wedge pressure to guide us, in patients without invasive monitoring, I will aim in patients with ARDS who are out of shock to try and get a liter off every day. It's hard to achieve because they're getting so much fluid in, but I will use lots of diuretics. I will use Lasix infusion or Bumex infusion. I will use more than one diuretic if they're not responding. So try and block the nephron at multiple levels to try and achieve at least even and hopefully a liter a day negative fluid balance.
Okay. Thank you, Prof. Lorraine, for the great explanation. And maybe that is the end of our session for today. We would like to thank you to Dr. Amy, Dr. Henny, and Professor Lorraine for the excellent discussion on community-acquired pneumonia. And on behalf of the committee, we would like to apologize for all the technical problem we are having now. Thank you for all the presenter and participants. We'll move on to our next session.